welcome everyone this morning to Nephrology Grand Rounds at the University of Washington. And we have three speakers this morning. Dr. Michelle Pengshung will launch Grand Rounds this morning, followed by Dr. Simon Su. And wrapping up, we have a visiting speaker who I'll ask Bessie to introduce before her talk, but Dr. Muki Ozier will be wrapping up in the third slot. So without further ado, Michelle, please feel free to go ahead, share your screen.
Okay. Okay, can everybody see that okay?
Yes, looks good.
Okay, great. So my name is Michelle, and today I'll be talking about HIF Prolyl hydroxylase inhibitors, or HIF PHIs, for anemia management. This has been a hot topic in the past recent years, was even in Neph Madness last year. And I just wanted to touch on this topic just because of how prevalent anemia is in our patients and how difficult it can be to treat, and how there has been a search for more promising new medications to treat anemia in our patients. And so I wanted to start off with a case of a patient, of a patient that I see on dialysis, Mr. RG, who is a 74-year-old male who has ESRD and has symptomatic anemia with fatigue, low energy levels, and weakness. And so these are some of his labs over months. And so this was back in May of 2021. As you can see, he had an iron saturation of 22%, a ferritin level of 1300, and a hemoglobin of 7.6. He was already on EPO at that time, and so we increased his EPO dose to treat his anemia. Despite that, he remained anemic, and kind of over months, we would continue to increase his EPO dose for his anemia. And he continued to have a ferritin level that remained fairly elevated. Occasionally, he would get IV iron infusions when his iron sats were low. And occasionally he would have a hemoglobin that would be at goal, but for the most part, as you can see, his hemoglobin has remained below 10. And he even had his EPO dose increased up to 13,000 units at one point, which is the dose that he's most currently on. And so I think that his case is probably similar to a lot of our patients that we see on dialysis, and kind of demonstrates how complicated anemia management can be and the limitations of our current management of anemia. And for him specifically, with his high ferritin, he demonstrates an inflammatory block that also plays a role in affecting how we're able to treat him for his anemia. And so I want to pose the question with this talk of how would you treat a patient like this, and would with a medication like HIF stabilizer be beneficial in a patient like him? And so the objectives of my talk, I want to first start by talking about the mechanisms of anemia in patients with CKD as they inform how we currently treat our patients. I want to talk about the limitations of our current treatment, and then briefly talk about ESA hyporesponsiveness. I then want to go into how HIF Prolyl hydroxylase inhibitors work, and evaluate the effect of HIF Prolyl hydroxylase inhibitors on anemia. Specifically, I'll talk about roxadustat, just because most of the data has been out on that drug. And then I want to talk about the safety of HIF stabilizers and how they compare to what our current treatment. And so anemia, as I said, is very prevalent in our patients with CKD. And the prevalence of anemia increases in frequency and severity in more advanced stages of CKD. In large-scale population studies, such as the NHANES data, which is shown here, the prevalence of anemia increases with from stage 1 CKD from 8.4% to 53.4% in stage 5 CKD. And anemia can have a dramatic effect on our patients' lives. It is associated with reduced quality of life, worse renal survival, and an increase in morbidity and mortality and higher costs. This is a graphic from a paper I found that showed that there was a positive and significant relationship between hemoglobin levels and quality of life, and showed that lower hemoglobin levels were associated with decreased energy and activity level and decreased work productivity. Anemia has also been associated with cardiovascular complications such as left ventricular hypertrophy, worsening heart failure, and angina. And then lastly, anemia is also associated with increased allogen sensitization, which is something to think about in patients who are to receive a kidney transplant. And for mechanisms of anemia and CKD, it's multifactorial. This is a graphic from Jason that shows some of the common causes of anemia and CKD, with the most common cause being decreased EPO production. We know that most EPO is produced by the peritubular fibroblasts in the kidneys, and in CKD, there's progressive reduction of endogenous EPO levels. Most patients with anemia in CKD also have iron deficiency, and they have both functional and absolute iron deficiency. They have an absolute iron deficiency when they have inadequate iron stores to meet the EPO demands to make red blood cells. And oftentimes we diagnose this by a low serum ferritin and a low transferrin saturation. And there are many reasons why patients with CKD have an absolute iron deficiency, such as they have increased blood loss related to dialysis, frequent blood draws, GI bleeding, uremic platelet dysfunction, but they can also have decreased iron absorption in the gut, and then also poor PO iron intake. Patients with anemia in CKD also have a functional iron deficiency where they have adequate iron stores, but they aren't able to mobilize that iron to be used. And this is often caused by inflammation. Inflammation can increase hepcidin, which is very important for the iron homeostasis. And this can lead to intracellular iron storage, so less iron is available to be used. And we often diagnose functional iron deficiency with low transferrin saturations, but normal or high serum ferritin. And then listed are kind of some of the other mechanisms of anemia and CKD, such as uremic inhibitors, enhanced red blood cell death, other nutritional deficiencies, and severe hyperparathyroidism. And so this leads me to kind of how we currently treat patients with anemia. And the goal of treatment is to increase hemoglobin levels, improve quality of life, and reduce transfusion requirements. And there's still controversies kind of regarding the goals of the hemoglobin to aim for and the best approach for management, which I won't really discuss as much in this presentation today. But we use iron to address iron deficiency, but there are limitations to using iron. For instance, for PO iron, it has poor absorption in patients on hemodialysis, and so it can be associated with GI side effects that may limit their use. For IV iron, while it has better absorption, there are concerns about it enhancing oxidative stress, exacerbating inflammation, and an increasing risk of infection. Also, with kind of the older formulations, there was concern about risk of anaphylactoid reactions. And overall, the optimal management of iron deficiency in patients with CKD still remain unclear. And then our other mainstay of treatment of anemia is erythropoietin stimulating agents, or ESAs. And these have been associated with risk of thromboembolic events, cardiovascular events, and strokes at higher doses through large randomized controlled trials that have shown this. And lastly, with ESAs, not all patients respond equally to ESAs, as demonstrated by the case that I initially presented. That patient had received escalating doses of EPO, but had not had an adequate hemoglobin response despite that. And so from that, I want to briefly touch on ESA hyporesponsiveness. There's not a clear definition, but the most frequent one used is that it's a failure to increase hemoglobin level into the target range despite large ESA doses. And ESA hyporesponsiveness is thought to be present in about 10% of our hemodialysis patients. And it has been associated with worse outcomes. And so this graphic here is from Kidney Medicine, and had looked at how ESA affects clinical and economic outcomes. And it was looking at data from Medicare dialysis participants and as a retrospective cohort analysis. And what they saw in this was that there was a difference in all-cause mortality between hyporesponders versus not normal responders, and then also patients who were hyporesponders had an increased incidence of cardiovascular events and also just higher healthcare resource usage. And so for those reasons, given the limitations of how we currently treat anemia and CKD, there's been a search kind of for promising agents that would address kind of, that would mitigate kind of the adverse effects that we see associated with how we currently treat anemia, and also to treat these patients who are ESA hyporesponders. And so this is where HIF PHIs come into play. And so HIF stands for hypoxia inducible factors. And they're part of a group of transcription factors that help activate a myriad of genes. And the system was elucidated by three scientists, William Kaelin Jr., Sir Peter Ratcliffe, and Greg Semenza, and they won the Nobel Prize in 2019 for this. But HIF is a heterodimer, and it consists of an alpha and beta subunit, with the beta subunit being constitutively expressed, and the alpha subunit expressed through an oxygen-dependent manner for the action of enzymes known as Prolyl hydroxylase domain enzymes. And so what this graphic shows is that under normal oxygen conditions, these enzymes hydroxylate the HIF alpha subunit, and this hydroxylated HIF alpha subunit can bind to the protein von Hippel-Lindau, and this then is polyubiquinated, and then it's targeted for proteasomal degradation. So in normal oxygen conditions, HIF alpha is virtually absent and isn't able to dimerize with the HIF beta subunit. In hypoxic conditions, the HIF alpha subunit persists and then can cross the nucleus to bind to the beta subunit and form a dimer and bind to hypoxia response elements, which in turn leads to the transcription of over 100 genes. And these genes are genes that are important in biological processes that facilitate oxygen and iron transport and delivery to enhance cell survival. And so they're involved in angiogenesis, in metabolism, and for our interest, erythropoiesis also. Particularly, particularly, they are involved in genes that lead to increased EPO production, increasing the EPO receptor, genes that affect iron metabolism, and then also genes that affect iron absorption from the gut. And so HIF stabilizers would kind of simulate the effects under hypoxic conditions, where the HIF alpha subunit would persist and be able to cause this gene transcription that promotes urfolpoiesis. And so the theoretical advantage of HIF stabilizers that we would be making we would be increasing our endogenous urfolpoietin levels, and thus kind of avoid supertherapeutic urfolpoietin levels that have been associated with adverse effects. And then, since it has an effect also on iron metabolism, it could be used in patients who may be ESA hyporesponsive and kind of address the iron sequestration that's underlying that. And so, going into the HIF stabilizers, there are 5 HIF Prolyl hydroxylase inhibitors in development. I've listed 4 of them here and some of their different characteristics. And the nice thing about the HIF stabilizers is that they're oral medications, and they're oral medications, so it may be a bit easier for patients to take. I'm going to mostly focus on talking about roxadustat, which is actually a medication that can be taken just 3 times a week. And so, looking at the studies for roxadustat, the first 2 phase 3 studies that came out came from China, and this came out in the New England Journal of Medicine. On the left side here is the data looking at patients who were dialysis dependent, and there were 204 patients in the roxadustat group and 100 patients in the EPO group, and they were randomized in a 2-to-1 fashion. And the main endpoint that they were looking at was the change in hemoglobin level over the period of time that the patients were in the study. And so what they showed was that the roxadustat treatment increased hemoglobin level by 0.7 grams per liter versus EPO, which increased the hemoglobin level by 0.5 grams per deciliter, and was non-inferior to EPO in both the intention to treat population and the per protocol population. Kind of their secondary endpoints that they looked at was kind of the percentage of patients who had a hemoglobin response. And it was similar in between the roxadustat group and the EPO group. And for the percentage of patients who had a hemoglobin of at least 10 grams per deciliter, it was 87% in the roxadustat group and 88.5% in the EPO group. They also did look at iron metabolism, which I didn't show the data of here, but they saw that in the roxadustat group, patients had increased total iron binding capacity and transferrin, and then also decreased hepcidin levels. In the study here on the right, it was looking at patients that were non-dialysis dependent, so with CKD stage 3 to 5 and not on dialysis. And it was a study that had an initial 8-week double-blind placebo-controlled phase in which they compared roxadustat to placebo. And then after this initial phase, all patients received roxadustat during an 18-week open label phase. And the primary endpoint was similar. They were looking at the mean change from baseline in the hemoglobin group level, but during weeks 7 to 9. And what they saw, as demonstrated by this graphic, was that there was an increase in the hemoglobin by 1.9 grams per deciliter in the roxadustat group, and a decrease of hemoglobin by 0.4 grams per deciliter in the placebo group, with a difference of 2.2 grams per deciliter. By week 9, patients who had a hemoglobin response, which was defined as an increase of greater than 1.0 grams per deciliter from baseline, was 84% in the roxadustat group, and then 0% in the placebo group. And so roxadustat was superior to placebo in increasing hemoglobin. These were fairly small studies, and then you may note here that there were more patients in the placebo group that dropped out compared to the roxadustat group, and this is kind of a recurring theme in the non-dialysis dependent trials that come later also, which they explained that more patients were symptomatic in the placebo group from their anemia and had to drop out compared to the roxadustat group. So, like I said, the studies in China were fairly small, and so there had been global roxadustat trials that were done, and they are all named after mountains. And so these are all the different trials that have been done. And so to look at the data from those trials, they actually did a pooled analysis of those trials. And so this is from Provenzano in CJSON. And so over those 3 trials, there were about 4,277 patients, and they were patients with CKD stage 3 to 5. And again, the primary endpoint was mean hemoglobin change from baseline, and they looked over a period of 52 weeks. And this graphic here shows kind of the mean hemoglobin change over the period of 52 weeks. For the least square mean change from baseline in hemoglobin, it was higher in the roxadustat group versus the placebo. It was plus 1.9 versus plus 0.2 grams per deciliter, with a treatment difference of 1.7 grams per deciliter. Again, there was a higher percentage of patients who had a hemoglobin greater than 10 in the roxadustat group versus placebo. And then patients who needed rescue therapy were higher in the placebo group versus the roxadustat group. Again, looking at the numbers here, which showed kind of the amount of patients over time, there were more patients in the placebo group that discontinued treatment over time compared to the roxadustat group. For the dialysis dependent trials, this is kind of a busy looking table here, but this is from an FDA analysis of the 3 trials, and it showed kind of kind of summarized the results of those 3 trials and showed kind of the change from baseline in hemoglobin average over weeks. And these trials compared roxadustat to EPO. And what it showed was that they all demonstrated non-inferiority of roxadustat versus EPO in these trials. So based on the efficacy, they looked at both patients, based on these trials, they both looked at efficacy in both patients on dialysis and not on dialysis, and found that roxadustat was superior to placebo in increasing hemoglobin, and at least non-inferior to EPO in increasing hemoglobin versus EPO. And then lastly, I want to talk about the safety of this medication, just because one of the purported benefits of using a medication like roxadustat would be that it would have less of the adverse effects than our current treatment of anemia. And so from that same paper from Provenzano and C. Jason, they looked at cardiovascular safety primarily, just because of the association of cardiovascular events with erythropoietin stimulating agents. And so they looked at a primary cardiovascular safety endpoint of major cardiovascular events, which included all-cause mortality, heart attacks, and stroke, and then also had a secondary composite endpoint that looked at MACE plus unstable angina and heart failure requiring hospitalization. What they noted was that roxadustat met the non-inferiority risk margin compared non-inferiority risk margin for major adverse cardiovascular events. They did, there was a paper that came out in Kidney International that looked at cardiovascular safety in patients on dialysis, and it seemed very promising at first because it noted that there was a 30% lower risk of MACE, MACE plus, and then all-cause mortality in this paper, and they had concluded that there was a lower risk. But this paper was actually retracted after reanalysis showed that patients on roxadustat actually had a higher risk of death, strokes, and heart attacks, and the confidence intervals were widened. And so the FDA did their own analysis of the data from the global trials, and what they saw in kind of the non-dialysis dependent patients was there were a signal toward more thrombotic events in patients who received roxadustat. As noted here, the risk difference was 1.1 per 100 patient years, with the relative risk being 1.45 based on patient years. There was also a risk difference for sepsis and septic shock and seizure that wasn't mentioned in the original analysis. Looking at deaths, the rate of death was noted to be higher in patients who had received roxadustat versus placebo, with a risk difference of 1.48 per 100 patient years, with a relative risk of 1.30. And from their analysis, it was driven by a higher risk of infection, renal deaths, and then sudden cardiac deaths. In the FDA analysis, it was also noted that there were more malignancies in patients on roxadustat versus placebo, though overall the numbers were very small. But this was of specific concern, just given that how HIF stabilizers work, it could affect many different genes. And one of the genes it can affect would be VEGF, which plays a role in tumors. In the dialysis dependent population, again, it looked at the relative, it showed that there was a slight trend toward a higher rate of death in patients who receive roxadustat versus EPO. And then they did note too, kind of for adverse events, serious thrombotic events and seizures were fairly prominent, which was concerning given that it was purported that these events could be avoided as we weren't having kind of the super therapeutic EPO levels as you would see with ESAs. And so, like I said, there was a special interest in major adverse cardiovascular events. In the analysis, it met the major cardiovascular event safety non-inferiority margin for patients with a hazard ratio of 1.10. But in the sensitivity analysis that the FDA did, the hazard ratio was 1.38, which excluded 1, meaning it was significant. Though they did note that it was hard to interpret this given the differential dropout between the placebo groups and roxadustat group, as mentioned previously, as this may lead to informative censoring. And then in the dialysis dependent group, again, it met the non-inferiority margin, but in the sensitivity analysis, it did not. And so I'm not going to really go over this too much, but there are, like I said, there are 3 other HIF stabilizers, and they all have their ongoing trials. It's still looking into kind of how they compare to EPO and placebo. And so just going back to our patient, Mr. RG, who is a 74-year-old male who has ESRD and symptomatic anemia. So he's already on high dose of ESAs and is iron replete. And so again, posing the question, how would we treat his anemia, and would HIF stabilizers be beneficial in him? I think that from looking through HIF stabilizers, it seems to be as efficacious as erythropoietin and superior to placebo, at least. But there are still kind of questions about the safety of these medications. And there had been signals regarding kind of if it increases major cardiovascular events and thrombotic events, which would make it kind of similar to erythropoietin and may not be a good addition kind of to our toolbox for anemia. And just for take-home points, this was an article that came out in JASN in just this month, looking at the search for the perfect agent for anemia management in chronic disease. And it talks about HIF stabilizers. And again, it says, you know, from the data, it looks like it's not inferior to ESAs in treating anemia. And there may be benefits in that it would better utilize iron in absorption and may be able to treat patients who are inflamed, but there are concerns kind of about the thrombotic risk and MACE risk in our patients. Any questions?
Thanks, Michelle. We're a little over time, but maybe one question if anyone has one.
Hey, Michelle, that was a really nice talk. Do we know that, you know, because like with scarred down kidneys, you don't expect the cells to produce EPO. So does HIF inhibitors, do they increase hepatic EPO production? I mean, that's another site, right?
Yeah, I don't think they specifically looked to see where the EPO was coming from when I was looking through the different articles. And I don't think, if I remember correctly, if they looked at the EPO levels themselves. I'm not quite sure where I guess it increases the EPO from.
All right. Well, thanks so much, Michelle, for a comprehensive talk, and we'll move on now to Dr. Soup.